But with that, I'd like to go ahead and welcome our healthcare and wellness faculty fellows and postdoc up to the stage. This will be a really quick turnaround type session. We'll be doing lightning talks from each of our researchers for 5 to 7 minutes. And then we'll have a nice Q&A session where we bring kind of the conversation. So as you listen to these talks, please hold any questions and then come back and come up to the mic similar to what we've done in the other sessions to ask any questions. But faculty fellows and postdoc from healthcare and wellness, go ahead and make your way up. So thank you, Isabel. With that, I will welcome Nicholas Tadanetti to the stage. He's a member of our external advisory committee and a professor and vice chair of operations of computational biomedicine at Cedars-Sinai Medical Center, and he'll be facilitating this session. So thank you, Nicholas.
Oh, yeah, great. Thanks, Penny. So I'm going to be very quick here. I'm very happy to moderate. We're going to get the lightning talks going, and then we're going to have a robust Q&A section. And so start thinking of your questions. And if you don't worry. I have tons of questions for our speakers to get us going. And then do you have slides? You want to step up to the podium? Go ahead, Isabel. So our first speaker is Isabel Freeling, Assistant Professor of Communication in College of Humanities.
All right. So I'm in science communication. I'm a social scientist, and I look at how people make sense of information to be able to use that for effective science communication. I do work on public engagement with science, and AI is one of the topics that I research in the context of science communication. And so what you'll hear from me is like about the societal perspective. How can we communicate this to society, to policymakers, etc.? And to have a good understanding of that, we need to know like how people actually understand and interact with AI. I put a few examples here. We have AI overviews now in our Google searches. We can go to different chatbots to get information, but we can also do that on social media. And everywhere we get content either summarized by AI or displayed by algorithms, so that not everyone is necessarily seeing the same content if they were looking for the same thing. And so if we look at these environments and research in it from like a science communication perspective, the problem is that not everyone is actually getting the same content displayed. So if we're looking at how people would then interact with messages, I can totally do that in an experimental setting where I show them a message, but then if they would actually ever see that message in the real world is a totally different question. So as academic researchers not having access to what people actually would see in the real world, that is really tricky because then, yes, we can do some more like artificial studies, but again, how well will they hold when we don't even know if someone would see that sort of message in the real world? And so in this PNAS paper, we wrote about some of those issues we're facing and have a visual that might be helpful to understand this a little bit. I wanted to visualize this like black box that a lot of interactions in current information environments are to academic researchers. So we have the social scientist here looking at what is going on different platforms. So we might be able to look at a little bit of single platform content data or a little bit at single platform user data, but there's a lot that's restricted behind this black box that we don't see where the actual online interactions would happen. So without good access to that data, it's then really hard to do the research that we so like urgently need on those topics. See, the next presenter is Maggie.
Thank you, Isabel. Next up, we have Maggie French, who's Assistant Professor of Physical Therapy and Athletic Training in the College of Health.
All right. Good morning, everybody. Thanks for being here and thanks for having me. I'm going to briefly talk about how we can use AI to improve post-stroke care. As many of us know, stroke is a significant public health problem. What I'm showing here on this plot is actually the annual per person cost of a number of different chronic health conditions. And on the far right for y'all is the annual cost per person for folks who've had a stroke. And it's pushing $60,000 a year for these individuals, far exceeding that of diabetes, OA, and even lung cancer. So there's clearly a cost economic side of stroke, but despite those costs, it's still one of the leading causes of disability here in the United States and globally. And what you can see in this figure is that these sources of disability include things like mood disorders, so depression and anxiety, cognitive deficits, as well as issues with physical function such as mobility. And in the current healthcare landscape, there's a really strong push towards value-based care, where we need to be providing quality care that gets good outcomes at a good price. And so for stroke in particular, there's a real question of how can we more efficiently provide care that gets us better outcomes. And so a lot of my work really focuses on how can we use AI to help make decisions about the care people are getting so that we can provide more valuable care. So I'm going to show you guys one kind of ongoing project that's fairly simple, but just to illustrate how we can use AI to help us towards this mission. And so the question here that we're trying to understand is how can we structure our rehabilitation interventions to improve mobility for individuals with stroke within a certain healthcare setting? And so in this particular project, we have developed two different lasso regression models. We're using data from the medical record here at the University of Utah. Our outcome for these models is a meaningful change on this tool called a care mobility score. Don't worry about exactly what it is. We won't get in the weeds. But here you can see from our data, we have about 68% of folks who have a meaningful change and about 33% who have not obtained a meaningful change while they were in this setting of care related to mobility. So in our first lasso regression model, we included what I'm calling non-modifiable factors. This means things that we as healthcare providers cannot change: age, sex, in this instance, characteristics of stroke because it's already occurred. The second model, we're including those factors as well as these characteristics of rehabilitation, things we can change. So here I'm just showing the results of those two different models. In pink, we have the model that has the non-modifiable factors as well as those characteristics of rehabilitation. And you can see that it outperforms the other model that only has those non-modifiable characteristics. And so, of course, the question is, well, what is it about how we structure rehab that contributes to the improvement in this model? And so what I'm showing here is just the top 5 most important variables in that model that includes both the non-modifiable factors and the rehab characteristics. And all I want to highlight here is that 3 of those 5 factors are things that we control in how we're delivering our rehabilitation services. And so the intention here is now we have insight into what factors can predict who's going to improve their mobility, and we can start manipulating those and see if we can improve outcomes based on those changes. Now, again, I mentioned this is really ongoing work, so I want to highlight a couple of areas where we're moving to and trying to improve. The first is in the granularity of our measurement of mobility. So this histogram here are the scores on that care mobility tool at discharge from our facility. And what I'm showing in the box here is that a lot of people are at the ceiling of that measurement. So are we really getting good, accurate measurements of their mobility outcome? Probably not, to be honest. And so some of the work we're doing with a collaborator of mine at Johns Hopkins named Ryan Romich is trying to figure out, can we use AI to better measure mobility? And so here we have an individual with stroke and their care partner walking. You see the colorful lines here. These lines are imposed upon a video using a computer vision model. And then from that, we can derive metrics of mobility that are far more granular than things like the care mobility tool. And to date, what we've seen is that this type of computer vision algorithm is actually very accurate, even in people who don't move like neurologically intact individuals. And so we're now trying to bring this to the clinic so that we can get more granular measurements of mobility. And we're trying to take it to the community so we can get information back into the healthcare system about how people move around their community. Finally, we're working on improving the data quality that we can get through the healthcare system. I have given a number of talks specifically about this, but today I don't have that much time, so I'm not going to. I will just direct you to some publications on what we're trying to do to improve the quality of the data that we're getting out of healthcare systems, improve the interoperability of data within one healthcare system and another healthcare system. And I'll just mention that the approach that my lab takes is to do this through something called a learning health system model, where we partner with clinicians, we partner with clinical operations leaders, and we really create this community who has a vested interest in generating high quality data that can be used to guide their clinical decisions. And with that, I will just acknowledge my funding sources, mentors, collaborators, et cetera. And I'll look forward to a conversation after everyone else's talks.
Thank you, Maggie. Next up, we have Pablo Maldonado. Pablo, come on up. And Pablo is a postdoctoral fellow in the RAI program.
First of all, I just want to say I'm so sorry that we're standing between you and lunch, but I think it'll be worth it. So I'm excited to talk to you about this project that we started just about a month and a half ago, which we hope will help address the mental health crisis that we see here in Utah. So depression rates across the US and in Utah have consistently been on an increase for more than 10 years now. And in Utah, what we generally see is that there is a higher rate of depression than the national average. So there is a critical barrier here, and that is the barrier of accessibility to mental health care services. And in fact, here in Utah, more than 80% of Utah counties are experiencing a shortage of mental health care providers. So what this means is that somebody that needs help has to either drive long distances to see a healthcare provider, or has to have a very long wait time. So they have to wait months before they can see somebody. So what usually happens is that they don't really seek help. So there is a critical need for expanding accessibility, both from geographically as well as also financially, because there is usually a large cost associated with getting mental health care. So to that end, our goal here is to develop a low-cost, accessible, multimodal AI platform that learns human behavior and can identify psychiatric symptoms across different populations in Utah. And to that end, what we're doing is we're leveraging smartphones, especially smartphone-based assessments, because approximately about 90% of people in the United States, of adults, own a smartphone. And here in Utah, more than 90% of households have access to the internet and have more than at least one device or more to access the internet. So this makes it a very powerful tool if you want to expand accessibility. So the first step in our approach here is that we want to develop a foundation model, a human behavior foundation model. So what this means is that we want to have a model that learns the basics of human emotion and then use that as a foundation to predict psychiatric symptoms using other data sets. So right now, I'm in the process of curating the data sets and just vetting. We're using publicly available data sets for the pre-training stage. These typically consist of paid actors that came in. They were recorded in a front-facing camera, and they were told to express an emotion, anger, sadness, happiness, etc. And they also speak a phrase with the same intonation. So our goal here is that we're going to go from video. We're going to use computer vision to extract the landmarks of the face so we can get a sense of what the face is doing. We're also going to get audio. So we're going to process and analyze the properties of the audio, so of how they're speaking, what they're saying. We're not going to take the context because in most of these pre-training data sets, the text or what they're saying is not really emotionally meaningful. You know, don't forget a jacket really doesn't really have any emotion to it. But our goal here is that we want to find a model that does the best in integrating multiple modalities, so visual, audio, and context and text. It is computationally efficient because we want these models to be available to the broader community so that they're easy to access and use, and perform well. So that's for the pre-training stage. Now for depression, what we have been working on is in collecting data from the local Utah population using smartphone-based assessment. So here, patients or the subjects are go through the PHQ-9, which is the clinical questionnaire used for depression to determine if somebody is depressed. And they also do a short video where they talk about how they're feeling on that particular day and what's going on in their lives. And that is the data that we're going to use to focus on depression. They're also taking other tests, such as for anxiety, suicidality, and PTSD, but for now, we're just focusing on depression. So there's some limitations to our approach, primarily from the data. So these public data sets lack demographic coverage. We're working on looking for other data sets that have better representation of different demographics. There's one particularly large one that has 20,000 videos that are from people from all over the world that we are considering using, but it needs to be vetted first. And for our clinical data set of depression, we're still working on collecting more data. And so one of the ideas that we have is to just set targets so that we can make sure that different populations within Utah are well represented in our data set. With that, just want to say thank you for your attention. And I just want to thank my mentors and Storyline, which is the one that is in charge of getting the clinical data set for us. So thank you.
Thank you, Pablo. Next up, we have Vineet Pandey, assistant professor of in the College School of Computing in the College of Engineering. Thank you, Vineet.
All right, my name is Vineet Pandey. I'm an assistant professor at the Kellett School of Computing. Very excited to talk about some of my research here. The first thing probably I would like people to know is I'm a human-computer interaction researcher. And with that, the positionality that I have for a lot of complex problems, such as AI in the real world, is that these are in many ways human-computer interaction problems. These are not core technology problems. These are about the people who are going to use the technology, how are we going to design the technology, and what happens when people actually interact with this technology. And so to do this kind of work, we need to have a bunch of different kind of skills. One of them is need finding, which is where we try to understand different people. So sometimes we might interview doctors, sometimes we might hang out with them in their clinics, and sometimes we might actually spend a lot of time doing ethnographic work with different patient communities or seeing whatever is it that they do online, because a lot of patient communities are really active online. In terms of technology, it's really important to understand, of course, the capabilities, the affordances provided by these really powerful AI systems. And yet, it's also important to remember that we have the power to design a lot of things out of these technologies. It's not an end all the way these technologies work and what they do right now. And with human needs in mind, we can redesign many of these things. And finally, it's really important to be honest about what actually happens when people interact with this technology and to be able to study that. So of course, this requires learning from many different domains, not just computer science. So one context in which my group does a lot of work of late is it's really neurological disorders. And so movement disorders are one category there. We are also working on a bunch of cognitive disorder related challenges. And so one of the things that we have figured out by running a need finding study, an interview study with movement disorder experts at the U, but also from other parts of the world, which is, in this paper, which is under submission, is that there is a high clinical burden, of course, across many domains. That holds true for movement disorder experts as well. There are about 660 movement disorder experts in the US, and about 6 or 8 actually serve rural areas. So, you need a lot of help and prayer if you're in a rural area and you have Parkinson's or essential tremor or something like that. Clinical assessments in movement disorders, unlike many different kinds of other health challenges, require subjective assessment by clinicians, typically in person. Now, often, of course, after the pandemic, a lot of healthcare work has moved online and telemedicine happens over videos. But my understanding, speaking with experts, has been that they don't really enjoy a lot of those. It also does not get at the core challenge in healthcare, which is the lack of enough expertise. So if the doctor still needs to be on the other end of the video call to assess you, you still require as many doctors and the time that they can put in. And finally, people often show up in neurological disorders to see doctors, to see other folks, therapists, when it's too late. And one of the things that I've learned working with a bunch of experts who are clinical researchers and also clinicians is that pre-symptomatic tracking can be really powerful, because even before the human perception system can figure out that you have tremors, there are signals that we can track. And so what we have been doing is, this is an ongoing collaboration with Movement Disorders Clinic at the U, with, Dr. Paolo Moretti's support, Dr. Jumana Alshaik's support. And now we are also starting to speak with therapists and people, in other aspects of movement disorders. So some of the challenges with current assessments are, it depends on doctors. Sometimes there can be inter-rater reliability challenges. Different people, on categorical scale, when you're assessing tremors and other movement disorders, people can disagree. Testing is very infrequent because, as I said, you need access to clinicians. What you get are these summative scores across movement disorders and cognitive disorders, which haven't really changed in 3 or 4 decades. There's been incremental improvement, but we have a lot of technology, but we are not capturing fine granular data that can provide us useful information, that can help us with, for example, pre-symptomatic tracking. And finally, everything takes a lot of time. Doctors are already busy. So the opportunity here that I see as a human-computer interaction researcher is that we can develop tools that assess motor performance remotely without having people on a video, but actually using your phone and performing a bunch of tasks. So we have designed tools before. I've designed tools before using mouse and web-based browser. Now we are using touchscreens, where people can use it in a few minutes. It generates interpretable features that clinicians really appreciate. If you speak with doctors, they're very clear that they cannot just start using an AI tool that tells them something about the diagnosis or the prognostic score or anything. They have to be able to explain it, both to patients as well as to regulatory agencies and insurance folks. And finally, there's a long and rich history in neurosciences and research to build on. This is one example, an amazing paper from experimental psychology about how you can dissect processing stages, whether people are thinking in parallel or sequentially, by basically tracking with very specific tasks on the phone how they move their finger. Fine finger trajectory can tell us a lot about a person's brain as well as their movement capabilities. So here's a task that we have designed. I say it's simple to use. It takes less than 2 minutes for most folks, normative folks. And it's simplest to design because it still took us many months to get to this simple format. It's called an alternating trails making task. And as you can say, you're supposed to move from 1 to A to 2, 2 to B, and so on. But what ends up happening is people often end up having errors. So one kind of error is a slip, where you're supposed to go from 1 to A, but you start moving towards 2. And at the last moment, you realize your error and you start changing, your particular trajectory itself. By tracking the time at which people make that change, by tracking the speed profile and carving a bunch of features out of it, we are able to, design these scores and interpretable features that correlate well enough with people's score on functional rating scales in neurological disorders. So that's one example. I think the possibilities are quite endless here. Clinically valid data collection in remote settings, once we get enough data from people around the world, it takes 2 minutes. You don't need to install any extra software, any extra hardware. And so, anyone around the world can use it. And so for rare disorder populations like ALS or even people with Parkinson's, you can collect a lot of valid data really quickly. So we are right now evaluating a bunch of these for validity in the clinical setting, and then we'll make it remote. These needs actually show up in a bunch of other settings. So I'll be quick with this. We submitted this paper about 7 hours ago, where we analyzed a bunch of comments by the ALS community, famous for Ice Bucket Challenge, on FDA's protocol about clinical trials. And they very clearly seek remote monitoring because it's very difficult for people with movement disorders to go to clinics and get assessed and all of that. The other end of this work that I'll talk about is not from the clinical side, but actually from end user and patient side, which is what is it that they need. And so, we focus on pregnancy. And we submitted this paper 7 hours and 45 minutes ago. And it's called, How is it that pregnant women actually go about finding information online? So, do they use AI tools, and what happens when they actually use AI tools for high stakes decision making and knowledge in pregnancy? And I was kind of glad to see that they don't seem to trust AI. So I'm going to drop in 3 things here. They see that AI provides contradictory responses, that when I keep reading, the answer goes from yes to no, as I keep querying the AI system itself. They don't quite trust it because they would rather talk to a person or a professional rather than an AI tool that they don't know about. And they find there's a lot of wasted effort, because if you don't trust something, you go back and test it again with other sources. And so pregnant women are using AI, but they don't trust it. And they still rely on some conventional ways. So I'll end there, and I'll once again repeat that a lot of these challenges are challenges of designing appropriate technology for specific real world needs. It's not about collecting terabytes and petabytes and exabytes of data. The tool that I showed you actually collects kilobytes and megabytes of data, but it's designed with clinical needs in mind and for it to run on any phone or any device with a touchscreen. So if you're interested in any of these topics, we do a bunch of other work with microbiome and citizen science as well. I'll be very happy to speak. I'll be around. Thank you so much for your time.
Thank you, Vineet. And our last speaker of this lightning talk session before we move into Q&A is Mark Yendel, Professor of Human Genetics in the School of Medicine. Thank you, Mark.
All right. So this talk's a little different from the others. This is more about AI applications here in Utah, specifically at Intermountain Health and the University of Utah, and a project that actually began last year called Gene Kids, rather substantial project with $12 million in funding from the Warren Alpert Foundation and from matching funds from Intermountain Health to extend whole genome sequencing and AI interpretive technologies across the Intermountain West. Before I begin, I should disclose that I am a co-founder, SAB member, and consultant of Fabric Genomics, which is a company that specializes in AI applications for genome interpretation. Fabric was recently bought by GeneDx. So there you go. So the Gene Kids project has 3 principal aims. Just walk you through a little bit and tell you about the role of AI and ML in those applications. The first is to provide whole genome sequencing and analysis across the entire Intermountain West. This is a strange figure that doesn't look like that on my laptop, but basically this is the project as of about a month ago. With respect to where in the U.S. children have been coming in to be sequenced here at Intermountain. We're obviously here in the Valley is the greatest density of children, but coming in from everywhere in the Intermountain West and even beyond now. The children being sequenced, if we were to try and collapse what are very often very urgent and complex medical conditions into a few big categories here, fall predominantly into 3 large categories. Neurodevelopmental delay, those are things like autism, problems with walking, movement, etc. Abnormal heart morphology, things like congenital heart disease, and finally seizures, epilepsy, etc. In the first year of the project, we sequenced about 300 children, and our diagnostic rate was 49%. That's pretty in line with other major applications around the country and the world. But what I'd like to emphasize here is the idea that you are definitively diagnosing half the children that are sequenced is utterly transformative for care. For so many reasons. And I'll show you an example a little later on about one such diagnosis. One of the issues with trying to scale up genomes-based medicine at the scales of, say, the Intermountain West or the US has to do with maximizing recruitment so that ideally every child that could benefit from genome sequencing is sequenced, but also practical issues of reimbursement, resources, etc., mean that obviously we don't want to sequence children that there's no reason to suspect genetic disease. For example, a child that's in the emergency room because of a fire or an automobile accident. This becomes quite a complex process in reality when you have something like a newborn intensive care unit with hundreds of beds, a very, very busy group of clinicians and support staff trying to care for these often desperately ill children. And so getting those people together, getting them to review the notes on each child in each bed, it's a very complicated, time-consuming, and expensive task. Over the last few years, we've developed a tool called the Mendelian Phenotype Search Engine that tries to automate that process using AI and ML. Basically, the way MPSC works is that nightly, all of the clinic notes and records for each child in an ICU at Intermountain are passed through an AI-based NLP pipeline. Machine readable descriptions of each candidate, each child are manufactured, passed to this tool called MPSC, which produces a dynamic queue that the physicians can log on, look at this queue, and evaluate each patient as a candidate for sequencing. This is from an early application in Rady Children's Hospitals in Southern California. This is a well-known, publicly available case that was discussed a lot in the media in California. It's a little boy named Hudson. And what you're looking at here are the MPSC scores on the y-axis, the blue line there, each day that this little boy sent in the emergency, in the NICU. And you can see he spent a lot of time there, 38 days, I believe it was in total. You can see first admission on day 1, his score was quite low. And then the red and yellow zones are the areas where the MPSC score, due to prior work, has shown that it becomes efficacious to sequence a child. You can see that on basically about day 20 or so, he crossed the red line there. Now, that's when MPSC would have recommended that the little boy be sequenced. It took quite a bit longer in this case. He wasn't actually sequenced until his health began to further decay. They felt he was near death, and they were just trying everything. So he moved out. Was diagnosed after sequencing within 24 hours or so with a known medical condition, and that told the doctors what they needed to do to treat that boy. And in a matter of hours, they literally brought him back from death's door. Unfortunately, he has lingering problems with hearing, vision, motor skills, etc., that are a product of the delayed treatment. So if he'd gotten treatment later, things would have gone better. Now, recently we showed that MPSC not only can identify these children after 30 days or so, but can do so within 48 hours of admission. And what we've done at Intermountain is set up a dashboard where the physicians can review every bed, see what terms are driving the score, see how it goes, compares to other sequence cases, etc. Now, just to finish up, I'd like to tell you about another aspect of this project, which is reanalysis. Our knowledge of human genetic disease is moving at a very, very rapid rate. New genetic diseases are constantly being discovered, new treatments, etc. And so it's important that often someone who was sequenced a year or two ago may have had a negative result, but not have a positive result now. And one thing that's greatly benefited all of these analyses has been an ongoing project at the University of Utah called NeoSeq. And this was an early proof of principle project for that helped get GeneKids funded. And so this is a bit about our reanalysis pipeline. For anyone that's been sequenced in the past. It consists of 2 AI tools and 1 backdoor data hub, all developed in part here at the University of Utah. GEM, now the dominant AI technology for genome-based diagnosis in the world. Another tool recently developed at Fabric Genomics called Transformer, which is an intelligent agent that reviews the recommendation of the GEM AI tool. So this is another thing that's going on with AI. You can think about AI says one thing, we want a human to review that, but often we'll have levels of AI in between that are going to review and keep track of what other AI tools think. This is patient 2018. This is a little girl with basically very common phenotypes, ataxia, global developmental delay, ADHD, etc. She was diagnosed with ataxia at 2.5 years. I mention this phenotype because this isn't a very specific phenotype. These are the kinds of phenotypes that you see in schools, children that struggle mastering basic skills at school. These are the children that we hear so much about with autism, etc. And so what is actually wrong with many of these children? It has been long a mystery. When this little girl was sequenced in 2023, there were 4 possible candidate mutations that were prioritized by Jim, but ultimately human review decided that none of these were convincing and the little girl was left undiagnosed.
Mark, we're going to have to wrap it up.
Rerunning these very recently, you can see with the transformer tool, we have a very enthusiastic diagnosis from that tool saying a human needs to look. And we now have a diagnosis, a definitive clinical diagnosis for that child, meaning that not only do we now know why she has those symptoms, but that the physicians can learn what are the best treatments. The family can be put in touch with individuals that specialize in that particular syndrome, et cetera. And with that, I'll walk off the stage because I think I'm about to.
Thank you. Don't go too far. I'd like to ask all the speakers to please come up and take a seat. And if you have questions, feel free to line up at the microphones and we'll call. And I'm just going to jump right in while we wait for some questions for the audience. Pablo, I really liked your presentation. I liked kind of the vision where you're going with it. And one thing that struck me was you kind of threw away the text and you said, well, the text isn't emotionally meaningful, so it's not going to tell you anything. But it occurs to me that LLMs are really good at generating text. And if you have maybe the same phrase said by several different by an actor in many different emotions, an LLM could probably generate context around that text to make it emotionally meaningful. Have you thought about different ways to integrate LLMs into enhancing your approach?
Yeah, that's a good idea. So we are still considering it. As a first pass, it did not make sense because, if I give you just a sentence, it just doesn't have any emotion to it.
Right.
But there are approaches that you can use to tie those sentences to the emotions, and that way the model can learn that there's also information there. We're still exploring them, but so as a first pass, we're not going to use it, but I think we're kind of holding off on the whole idea of that.
Cool.
Yeah.
Very cool. Go ahead.
Great. Am I audible?
Yes.
Okay, great. I have a kind of specific question, and maybe Dr. French will be the best person for this, but I'm wondering how you deal with confounding in teacher outcome relationships when you're trying to interpret the results. Like time in physical therapy, for instance, number of minutes might be negatively associated with a positive outcome, but really it's because of how severe the disease was. And maybe I misunderstood the results, but I'd love to get any of your thoughts on that. But.
Yeah, that's a great question. So when we think about using AI in healthcare, you've got to be careful to make a distinction between causation and something being predictive. Being predictive doesn't necessarily mean that's causative. And so, the model that I showed, it wasn't the case in this particular model, but maybe you're seeing that something that you think should be associated with a positive result, maybe you aren't finding that, right? And is that a causative relationship or not? And that's what you really have to disentangle when you have these predictive models. And so some of our next steps that I didn't really harp on here is, well, what happens if we tweak that, right? Is that the actual variable that we need to target because it's causative, or is it not? Right. So there is a very important distinction between causation and predictive ability.
Thank you. And if anyone else wants to jump in for any of our questions that get asked, feel free to. Go ahead.
I have a question for the gentleman with the white beard. I'm sorry, didn't catch your name. But the project that you're on is of specific interest to me as an individual and also as a software engineer. But in your research and in your collection of all the data, are there any specific markers that we are looking at that cause autism or get people on the spectrum?
You hear me?
Yeah.
So first off, I'm not a clinician. I am a human geneticist. So I think the most important thing that
Mark, do use the microphone. Just hold it a little toward your.
Yeah, okay. One of the most important things to understand about autism is that it has many diverse causes, not all of which by any means are genetic. But it is in aggregate common in the population. And so I think although sequencing is not going to solve and explain all of autism, it's going to explain a significant portion. But not only that, the particular problems and different subtle types of autism and the outcomes for different individuals with them are going to be better informed by being able to say, well, let's take all of the individuals and children with this particular type of autism, let's link together the physicians, the parents, et cetera, and find out what works for that subset. I think that's a very big process that's going on around every genetic disease in the world today.
Thank you for that. Quick follow-up is that we work pretty closely with URAD that gathers data on autism and people on the spectrum. And after DSM-5 was released, there looks like there's a correlation between the number of people being diagnosed and the release of DSM-5. So the comment is that the sooner we can get to the root cause, which could be genetic, in my personal opinion, the better off we'll be.
Thank you.
Thank you. Over here.
Thank you for those lightning presentations. Laura Marquez with UHealth. I lead out on digital transformation. This question is specific to Vineet and Pablo. I have evaluated several companies that are in similar spaces. And what we hear from clinicians is a reluctance for more data coming into the EMR, especially because it needs to be integrated because that's where our clinicians live and breathe, right? But for example, if we're identifying patients, who might be having a mental health crisis or might be, looking like they are suffering, from a mobility or a cognitive decline, the clinician's sentiment overall is we can't handle yet another input into the system because we don't have the resources to, especially in the mental health world, in those kind of crises moments to respond. And then the risk for our organization skyrockets if we can't give, care in an adequate time. So I'd love to hear your perspectives, what you're thinking about, how to help our clinicians.
Is this working now? Great. Yeah, fantastic question. I completely agree with you. In fact, for some of my talks, I do start with a critique of the general approach of we'll track a lot of data using smartphones and we'll throw it into the clinic. That kind of approach is what is categorized as passive digital phenotyping. A kid with a pediatric ataxia might be wearing a smartwatch with a lot of sensors and walks around and does things throughout the entire week. And we collect a whole bunch of data and we analyze it and, it's useful. But doctors do not want to get started with that because they're extremely busy already. They're not able to, keep on top of their responsibilities, more data, who's going to deal with it. Absolutely agree. The approach that I'm talking about is instead it's called active digital phenotyping. And the idea there is that you're designing these really precise tasks. It's not about people using the same device, for a very long time. In fact, people will show up once every week on this web browser link that we have created, and they'll use this thing for, a couple of minutes. And that provides us information about their fine finger trajectory that teaches us more about their movement disorder challenges, or if you're talking about cognitive impairments, what's going on there. And the idea there is, of course, it's really important to show the output in appropriate ways. And that's one of the reasons when we are validating this tool, and I've done this work, as I said, with mouse and web-based browsers, we validate the data that we get out of this, we run models on it, and we try and come up with clinical scores on the same scales that clinicians actually diagnose and track progression on. So what clinicians are seeing are not, all of these rich feature data that we see as engineers under the hood, but they see data that they really care about. It's almost like, do I have another clinician who actually rated and scored this person, and that person's telling me what's going on? And that's the part of this active digital phenotyping task. And the challenge, of course, is to design these tasks to be, actually valid, to design them to be precise, to design them to be very usable for people with motor impairments. It's really a challenge for them to be able to use, devices and so on. So that's the key difference. And of course, very good point. And, that's, we try and make that happen.
Anyone else want to?
And so I totally understand this idea and the tension between we need data so that we can make informed decisions. But as a clinician, you get a lot of data and it's hard to know exactly where to draw your attention and where to really focus. And so the approach that we've taken, I do some work kind of in this remote monitoring space as well, is, okay, so can we get the data in, but then is it meaningful and does the clinician need to see it? Right. And so before it should even go into the medical record and the clinician should be able to see it, it has to be connected to some sort of meaningful action that the clinician needs to take. And without that step, you're just going to be producing more and useless information for a clinician that they can't take action on.
Go ahead.
Polina Kukhreva, Department of Biomedical Informatics. I have a question for Pablo. I really like the idea of measuring emotions, and I know a lot of people are interested in quantifiable self movement and on N-of-1 trials where you can do experiments on yourself, for example, to find out if a specific medication is working for you, and there are even apps for that. But something these apps are currently missing is actually quantifiable metric of your emotions. So do you think your foundational model could result in quantifiable metrics which could be imported in Apple Health and then exported into these N-of-1 trial apps?
Yeah, so that's a really good question. It really depends on the model that is being trained and what it can identify. Our first approach is to use an unsupervised method that will not really know what anger looks like, but it will know that it looks different from happiness. So that's one thing to consider. I think that there is potential for including these sorts of data sets and more information as you're feeling, but even for humans, it's really hard to say, how happy are you right now, right? And the objectiveness of it is a really difficult problem that it's really just really hard problem, I have to say. I'm happy right now, but I'm not sure if it's a 6 or a 7 or an 8.
Thank you.
We're using some kind of similar computer vision models. And one of the things that we're finding, I of course use it more in the mobility space, but some other folks are using it in measuring the facial movement related to motor function of the face. But you can get really precise measurements about, how big is your smile? Like we can put some numbers on that. And so to your point, like there's probably some ways that we can use some of these computer vision models to get much more objective measurement beyond, my 0 to 10 on the happiness, I guess, I don't know, that maybe worth exploring from this technology.
Thank you. Yeah, go ahead, Vinny.
Right. So I have a response that's actually, tied to the last two questions, which is, so one of the things, we talked about self-tracking and self-experimentation and the challenge of, these really subjective factors. Of course, we need, for the right cases, when it's possible, the right sort of quantitative bit. But it's not just about data, but it's about rigorous analysis, valid insights out of that. And the way you do that is, of course, by scientific experimentation. And so one of the advantages when you have devices, either the kind of technology, that Maggie's group is building or my group is building, it's about being able to let people try out more things about their own health disorder as well. When someone with a movement disorder sees their doctor once every 6 months, there's only as much they can discuss in 20 minutes. And what's more necessary is to kind of think about a more participatory model of healthcare, Because if you have ever been a caregiver for someone, you already know that you take on a huge lot of workload that typically, if you had access to clinicians, they would be doing. And so can we actually design, both data collection tools, self-experimentation toolkits, which are rigorous, valid, where people can co-design experiments with clinicians and run them and figure out whether dietary changes helps their health or something else, or physical exercise. And I think moving towards that model where we include more members of society into doing medical work that helps them, can be really rich and promising.
Thanks, Nate. So I'm going to take my prerogative and ask the last question. I wrote this down during Isabel's talk, so I want you to answer first, but anyone else can chime in. We've spent a lot of times in statistics. So statistics has spent the last 50 years teaching people that the end matters. If you ask somebody, oh, you saw that study, and they'll be like, oh, but how many people were in it? Or what was the size of the study? We're kind of in a post-N era, and I think it's totally different now with AI. So if there was going to be one thing that you wanted the public to understand about AI, to have in their toolkit to interpret or doubt an AI result, like what would that be now?
Okay. That's a really big question.
Just to let you have like 30 seconds, so
I would say like that they can use it in a way that they understand the limits of the tool, but also in a way that it's useful for them. Like they need to know they cannot put every data into that tool, right? But also what comes out, like what is the model based on? Many people don't know. Many people also don't know hallucinations exist. Like we know because we work in this space, but normal people who do not all the time think about the specifics of AI might not be that aware. So in that sense, maybe we need to work more on AI literacy, like we've worked on media literacy in the last few years, to really have people understand like what this tool can do and also what it cannot do.
Yeah.
So I teach in our Doctor of Physical Therapy program here at the U, and this is something we're thinking about in our curriculum quite a lot, is how do we teach our students to appraise the literature that's coming out and using different forms of AI so that they can stay abreast of current knowledge. And this is something we're really struggling with it. Like how it's so different than understanding how to interpret a regular linear regression where they're just showing you the beta coefficients and you're like, oh yeah, they were powered appropriately. And so we're struggling with that. How do we train the future clinicians who are almost certainly going to be having some sorts of AI tools embedded within their clinical workflows to appraise how those models were developed? So not really an answer for you, but I think it's a great question.
Excellent. Please join me in thanking our speakers.